Welcome back to Mayo Clinic Radio. I'm Dr. Tom Shives.
And I'm Tracy McCrae.
Tracy, there are a lot of people in this country who have given up cigarettes. According to the CDC, cigarette smoking has fallen to its lowest point in recorded history. In 2017, that's the last records that I could find available, an estimated 14% of adults smoked. That's about 34 million people, and that's nearly a 70% decline from 1965, when just over 43% of American adults smoked cigarettes, tobacco smokes. But now we've got e-cigarettes.
Yeah, the teens are starting to pick up the slack.
Vaping.
Juul, the most popular e-cigarette on the market, was created to help smokers switch from cigarettes. But in fact, e-cigarettes have complicated this tobacco product landscape. They're not an FDA-approved quit aid, and now using e-cigarettes and vaping has become an epidemic among young people, including high schoolers. Here to talk about quitting smoking, nicotine addiction, and e-cigarettes and vaping is Dr. John Ebert, Associate Director of the Mayo Clinic Nicotine Dependence Center. It's good to see you again, Dr. Ebert.
Pleasure to be back. Thank you.
Well, I can't wait to hear the Juul story. But first, let's talk about congratulations to you and your colleagues for getting the smoking rate down to the lowest it's ever been. So how'd you do it?
So I think it was always a combination between public policy and then effective treatment. Most patients who quit smoking quit on their own, and I think a lot of that was clean indoor air and a lot of the local policies that were implemented to kind of restrain or constrain smokers. Because we know that if you have clean indoor air and good public policy, people are more likely to quit. In combination with that, good effective therapies like varenicline and bupropion and nicotine replacement have really been disseminated pretty well across the country. So we've done a good job on both reducing the incidence of people starting to smoke through public policy, but also treating effectively those people that are chronically dependent.
Now, for a long time, we didn't really know how detrimental smoking was. Wasn't it 1960 when the Surgeon General's report came out and they said that there was a connection, a link between cigarette smoking and lung cancer? Nothing about the heart, nothing about your increased risk for stroke, right? I mean, we didn't know how bad this was.
So it took a good long while, and that's the challenging thing, I think, is when we talk about e-cigarettes that we'll have to sort of discuss and think about. It takes a good long while for a large population of people to be using or abusing a substance before we can actually start to truly understand what the true health risks are. So we started mass producing cigarettes for our troops in the early 1900s, but it wasn't until 1950s, until JAMA came out with the case control study associating smoking with lung cancer, that we were like, oh, there's something really going on here. So it took about, 30 or 40 years to get that data out there. And then we could start to piece the other, the heart and the lung and the liver and the nerves and the brain and all those other things together. And everything else, right? It took a while to get, but it takes a while to understand what the health risks are in a broad population of patients.
And today, in the 21st century, if you're smoking, I would say you probably know that you should not be smoking. I don't think there's any discussion there, but it's the nicotine that makes it so hard for people to give up smoking.
Correct. And I think what you're seeing too, it's interesting. It's not just smoking yes or no, but the types of smokers that we're seeing. So back in the 60s and 70s, the vast majority of smokers were daily smokers. What we're seeing now is that a significant percentage of these patients are non-daily smokers. So they smoke occasionally. So there may be some differences in risk perception. I think that the message is very clear. If you're a daily smoker, that there's these attendant health risks, but you will get patients coming in and saying, but I don't smoke every day, doctor, so what is my true health risk? And that's due to some of these complexities of understanding risk and communicating risk and public policy. You're not a daily smoker, so actually sitting in a restaurant for 4 hours is not very hard. But your risk is when you leave that restaurant and smoke. But being in that restaurant for 4 hours doesn't make you quit. That's the deal.
Is there any drug that's more addictive than nicotine?
So abuse liability that's an excellent question. And I think we always struggle with that when we talk about addiction is what makes something addictive or what makes something reinforcing. So it's all about reinforcement. Nicotine and heroin and alcohol all have different complexities with relation to the legality of them. So how do you measure addiction? Is it reinforcement? Reinforcement is different for everybody. And you may look at just the prevalence across the population and say the most prevalent drug use is cannabis, but it's not the most addictive. So there's a lot of other things that sort of play into what addiction is. And so it's hard to say, but there's no question nicotine is incredibly reinforcing.
And doesn't it get to your brain pretty quickly after you inhale?
Correct. And when we talk about addictions and we talk about drugs of addiction and drugs of abuse, and we talk about what is really making someone continuing to use a substance, it has everything to do with reinforcement. And reinforcement is directly related to how quickly you can get a drug into the central nervous system and in what concentration. And there's nothing that is faster than pulmonary delivery or a drug delivered through the lung.
You know, I think I remember Richard Hurt saying, Dr. Richard Hurt, who was part of the Nicotine Dependence Center for so many years and did so much great work. But he said, you know, if alcohol got into your system as fast as nicotine did, it would probably be just as addictive.
Yes, absolutely. And once again, it's a speed of delivery. And when people smoke heroin compared to injecting heroin, it's a faster delivery, so it's much more reinforcing. So I think that's generally true.
So, as I said, anybody who is smoking knows that for their health, they should not be smoking. So, what is it that has changed in the decades to make it easier to quit smoking? What are some of the aids that work?
So I think the aids that we really talk about are really three. And I sort of lament as a primary care clinician that smoking kills 480,000 people each year, and I've got 3 drugs that I can use, and erectile dysfunction kills no one, and I got 50. So it just shows you where we put our priorities. But anyway, so I think the drugs are nicotine replacement, and bupropion, which is an antidepressant, and then varenicline, which is a medication that actually blocks the nicotine receptor. Those are the 3 drugs we have.
And what are the trade names of those?
So
Chantix, one.
So Chantix is varenicline, and bupropion is sold as Wellbutrin or Zyban.
Okay.
And then nicotine, there are many different nicotine replacement. Nicorette is one.
Okay.
Those are the different products.
Yeah. All right. And tell us about your success rates now. I know you've got several different programs at the Nicotine Dependence Center. Just outline briefly what those programs are and your success rates.
So we know in tobacco treatment that there's a dose effect. That is, the more intervention that you provide, the higher the success rate. So for example, if you talk about a quit line where you can disseminate to a broad population and anybody in a state can call in a quit line, our quit rates in a quit line, for example, are about 3 to 8%. Those are low rates, but it's across a broad population. And so when you get more intervention, like face-to-face, like we have the Outpatient Nicotine Dependence Center, our quit rates are about 25% at 6 months to 12 months.
So that's counseling, basically.
Counseling,
Talking.
correct. Yeah, thank you. Yeah, so it's counseling.
But that's without any nicotine replacement, without any drugs.
Right.
You're
so
at 25%.
Yep. And then when you get into the residential treatment program where you're providing nicotine replacement and you're inpatient basically for 8 days, in the building two blocks down from here, we take patients in and put them in for 8 days, and we provide them intensive counseling and work with them with medications. Our quit rates are about 50% at 6 to 12 months. So not 100%, but the more intense the intervention, the higher your quit rates.
But you can also prescribe nicotine replacement and some of those drugs as an outpatient. They don't have to come in to get those.
Correct. That's a great point. The nicotine replacement therapies that are available over the counter are the gum, the patch, the lozenge, and then there's an inhaler and a nasal spray, which are available by prescription. And then the bupropion, which is the antidepressant, is available by prescription. And then varenicline or Chantix, as you mentioned, is available by prescription. So some of them are over the counter and some of them are prescription.
All right. Well, the lowest smoking rates ever in the United States. Pretty impressive. No question about it. Nicotine is extremely addictive, but millions of Americans have been able to give up cigarettes, many with the help of people like our guest today, Dr. John Ebert. Quitting smoking expert Dr. John Ebert. Time for a short break. When we come back, we're going to talk about e-cigarettes, vaping. Are they a public health threat to America's youth? Our guest is a quitting smoking expert, Dr. John Ebert. We've talked about all of the things that he and his colleagues have done over the past decades to get the smoking rate at the lowest rate it has ever been in the United States, which is pretty impressive. Only 14% of the population still smokes, so some 30 million people or so. But now the landscape has been muddied a little bit by what are called e-cigarettes, which have become extremely popular among young individuals. In a word, what do you think of e-cigarettes?
So the challenge with e-cigarettes is it really presents a unique and really sort of unparalleled experience in public health where a device could be used to help one group reduce their risk for dying from tobacco-related illness, at the same time increasing the risk in another population.
Yeah. Are e-cigarettes vaping, and is all vaping e-cigarettes?
So most of the time, e-cigarettes are kind of referred to generally or generically as anything, in one of these vaporization devices. There are e-pipes and e-cigars, but really I think that terminology e-cigarettes refers to any of these vaping devices generally.
Now, what I understand about vaping and e-cigarettes is that the levels of nicotine are so much higher than a regular cigarette. Is that true?
So when you talk about higher, there's a couple things that you can talk about. You can talk about the content in the e-liquid, or you can talk about the delivery to the user. There are some studies that demonstrate that users of e-cigarettes, electronic cigarettes or e-cigs, are higher than people smoking conventional tobacco cigarettes. So yeah, we do see that in some populations.
So you're even more addicted because you're getting even more nicotine.
So there is, so that theoretically is a potential adverse consequence of being exposed to more of a drug as you potentially are more dependent.
Well, one of the things I've heard is that the concern is that teenagers will vape and then they will become a cigarette smoker, but I'm not sure why they would ever take a step back, like they would use a cigarette as their step down method from vaping because the level of nicotine is less.
Yeah, so I think the question really is if you look at, so if we just take smokers who smoke conventional cigarettes out of the equation and just really talk about adolescents and ask the question, what's really happening and what's going on in that population? We're concerned about the thing that you mentioned, which is adolescents using e-cigs and then actually going to conventional tobacco cigarettes, harm escalation, if you will. So they're increasing their harm. And you're wondering if that is outweighed by the likelihood of kids who otherwise would have smoked conventional cigarettes who don't because they can use e-cigs. And on balance, it seems to be that both things are happening. It's probably true, if you look at the population, that kids that would have wound up smoking conventional cigarettes anyway are probably less likely to be doing so because they can continue on the e-cigarettes. But it's probably also true that adolescents who never would have smoked conventional cigarettes are more likely to be doing that because of the gateway phenomenon of electronic cigarettes. Both things are happening. The question is, what is the population impact overall, and what do we as a society want to do about it?
So the most popular e-cigarette out there is still Juul?
Right. That is correct.
And the two guys who started that company said that they wanted to make tobacco obsolete, wanted to make cigarettes obsolete. But then what happened? I mean, all the youth in America, so it's very popular in high schools, it's very popular in colleges, and they didn't really intend that, but it's turned it into a $16 billion company.
Correct. And I think when you look at intent and you look at what they say, you may infer two different things. One of the things that I think you could say is that if you hadn't designed Juul to look like a flash drive, perhaps not as many adolescents would use it. If you hadn't made it so small and concealable, perhaps not. So there's a lot of issues that when you look at intent and you look at the design of these products, might actually influence who takes them up. Let me give you an example. So there's data out there in the literature that suggests that if you're a smoker smoking conventional tobacco cigarettes and switch to e-cigarettes, you're more likely to use a device that looks like a conventional cigarette. But if you are a never cigarette smoker, you're more likely to use something that looks like a flash drive. So intent and design could be a way that you think about figuring out exactly what's happening in the industry, what's happening in the market, and who's more likely to use what product.
That's fascinating.
Yeah, truly. So when we're talking about e-cigarettes and the nicotine content, but these are not regulated, so there's potentially some other stuff in there, isn't there? Like carcinogens and THC and toxic chemicals, right?
Absolutely. And when we're looking at these devices, it's fascinating to think about how those toxic chemicals are being created. So the devices work by using a heated coil, and that coil is metal, different types of metal, nichrome and kanthal and stainless steel and nickel and titanium are the classic metals they use. And what happens is when you take an e-liquid, which contains formaldehyde, or it doesn't contain formaldehyde at baseline, but contains vegetable glycerin and propylene glycol, and you heat that with one of those metals, you produce formaldehyde through the heating and the oxidation process of those e-liquids. So it is potential. It is a potential to think about aerosolization in a different way, not through heated, that could potentially reduce the risk. There's data out there, very interesting, that suggests when you look at e-liquid, before you aerosolize it or make it a vapor, and then you actually make it a vapor with the heated coil, you produce 18 new chemical species that didn't exist before.
Wow.
Pretty amazing. So these e-cigarettes, as we mentioned, are extremely popular. Why? I mean,
Yep.
Is the nicotine high? Is it what it does to kids' brains?
So I think that it is a fascinating and important consideration that an electronic cigarette is a unique marriage between device and drug. So we live in an iPhone society where a lot of these devices have digital readouts, and you can adjust things, and you get feedback, and you can track puffs, and it's kind of like an app. And it also contains a drug. So your iPhone is just a device, but if the iPhone was, married to a drug, an iPhone plus drug, it would probably be the most addictive thing or potentially reinforcing thing out there. So I think there is a unique experience of the device and drug, and that's really what I think explains the e-cigarette phenomenon.
Well, now the FDA or the FTC or whoever it was outlawed flavoring cigarettes, tobacco cigarettes, but you can flavor e-cigarettes. How does that work?
So a lot of that is because the FDA, their deeming privileges or their oversight of this industry has not been currently enforced. And there are lots of interested parties out there who want to restrict flavors, so they don't want to have any flavorings for e-cigarettes. And there are groups out there that are advocating for that at the national level. But that's just because it's not regulated is why you get 7,700 flavors.
I had to laugh when you asked the why question, because what I've been thinking for the last 10 minutes is when I was a teenager, all the old people in my life, if you ask them about cigarettes, they would say, well, you look stupid when you're smoking. You look ridiculous. And I thought, well, I don't know. I think they look kind of, tough, kind of cool.
Kind of cool. Yeah, like the
and
Marlboro Man.
Now, when I see kids or young adults vaping, I just think that looks so stupid. I can't believe it. Mm-hmm. And I think, wow, I am
matured. You've matured.
Well, it's something about just like the old people in my life when I was a teenager. So there is definitely something to that.
What's interesting is I've been informally interviewing patients who come into our treatment program and asking them the question of, you're trying to quit cigarette smoking, conventional cigarettes. Have you ever used an e-cigarette? And, very frequently they'll say, yeah, I tried it, but it looks stupid.
So
and these
funny.
are smokers of cigarettes. So there are different perceptions and tastes.
Have you been dealing at the Mayo Nicotine Dependence Center with people who are addicted to vaping?
We have not. Usually people addicted to vaping are not seeking treatment.
Okay.
Yeah.
Would you say that vaping is a safer alternative to tobacco for adults?
So for adults who are trying to quit smoking, I would say that electronic cigarettes are 95% safer than conventional cigarettes.
All right.
They
there
just
you
look
go.
stupid.
Yeah, they just look stupid. Sure. All right, Dr. John Ebert.
Okay.
Well, cigarette
Sorry.
smoking has fallen to its lowest point ever. Only 14% of Americans still smoke. Fewer young people are starting to smoke. Older smokers are dying, and others are quitting. But now we've got a new problem. E-cigarettes, a new way to get addicted to nicotine and a popular pastime among America's young people. Unfortunate, I guess. Our thanks to Dr. John Ebert of the Mayo Nicotine Dependence Center. Great to have you with us.
Thank you for letting me be here.